Welcome to another Explainer. Today, we're going to take what could just be dry, textbook medical science and transform it into a really fascinating look at a mechanical failure behind a totally universal annoyance: heartburn. We so often dismiss it as just the penalty for eating a late-night slice of pizza, right? But medically speaking, there's actually this incredibly structured cascade of events happening right inside your chest. So we're going to unpack exactly what goes wrong when that familiar burn sets in.
Okay, let's start by totally normalizing the baseline here. The movement of gastric contents into the esophagus, that happens in literally everyone. We all experience this multiple times every single day, and it's just a standard, normal part of human digestion. But it crosses the line and becomes pathological when your body's anti-reflux mechanisms fail badly enough to allow prolonged acid contact with the super delicate lining of your lower esophagus. And when that happens, well, we're looking at gastroesophageal reflux disease, better known as GERD.
So here is the roadmap for our explainer today. We'll be hitting 5 main stops. First, the anatomy of acid reflux. Second, triggers and root causes. Third, heartburn versus a heart attack. Fourth, diagnosing the damage. And finally, number 5, putting out the fire.
All right, Section 1, Anatomy of Acid Reflux. Let's look at the mechanical valve that stands between your stomach acid and your throat.
The absolute most crucial point to understand here is that GERD is fundamentally a mechanical plumbing issue. Think of your esophagus as a 25-centimeter tube. Right at the very bottom of that tube, there's a tiny 4-centimeter band of smooth muscle called the lower esophageal sphincter, or the LES. Now, its entire job in life is to relax just after you swallow to let food in, and then immediately clamp tightly shut. When this tiny 4-centimeter gatekeeper fails, that's when prolonged acid contact just wreaks havoc on your mucosa lining.
So in a perfectly functioning system, once food passes through, that sphincter naturally and completely closes up. In this state, there's absolutely no reflux. The stomach is totally free to churn all its highly acidic digestive juices without any risk whatsoever of those contents splashing upward into your unprotected esophagus. It's a great design.
But things go wrong. When that 4-centimeter muscle relaxes abnormally, or if it just loses its tone, a physical gap opens up. This allows those highly acidic stomach contents to just freely wash back upward. And this abnormal acid reflux is exactly what causes that familiar, fiery, burning sensation and all the subsequent damage to the lower end of the esophagus.
Moving on to Section 2, Triggers and Root Causes. What exactly causes a system that usually works so perfectly to suddenly leave the front door wide open?
Well, the mechanical failure basically comes down to a battle of physics. There are 2 main forces that push this valve open. Either you have excessive upward pressure from the abdomen that physically forces the sphincter open from below, or there's a weakening of the sphincter's own muscle grip, meaning it just doesn't have the strength to stay closed against totally normal stomach pressure.
And the things that cause this are surprisingly common. From the joys of pregnancy to simple weight gain, or even just heavy lifting at the gym, increased abdominal pressure is literally squeezing your stomach contents upward. On the flip side of that, your morning coffee, fatty meals, chocolate, smoking, and alcohol, they actively relax or weaken that sphincter tone. Add in structural issues like a sliding hiatus hernia disabling your diaphragm support, and you realize everyday factors are secretly conspiring to break down your defenses.
Let's jump into Section 3, Heartburn versus Heart Attack. This is a super high-stakes confusion, and we really need to distinguish a simple tummy ache from a deadly cardiac event.
Because acid reflux can trigger severe pain that radiates deep into the chest, it creates a genuinely terrifying scenario. Medical literature specifically notes that angina-like pain is actually a main feature of GERD, so patients rush to the emergency room, totally terrified they're having a heart attack. And doctors have to quickly and accurately make a really serious medical distinction, often using a resting and stress ECG, just to confidently rule out angina before they even think about treating the reflux.
But when you break down the differences side by side, it's actually pretty fascinating. GERD generally produces a burning pain that gets triggered by bending over, stooping, or lying down, and it's almost magically fixed by taking antacids. Plus, it usually stays right behind the breastbone. Angina, on the other hand, that's a gripping or crushing pain produced by exercise, relieved by rest or nitrates, and it viciously radiates into the neck, shoulders, and both arms, often accompanied by sweating and shortness of breath. 2 very different beasts.
Section 4, Diagnosing the damage.
Okay, so once we've successfully ruled out a heart attack, how do doctors actually evaluate the structural damage happening inside your throat?
Here is a wild fact. You absolutely cannot trust your own pain levels as an indicator of danger. The medical literature points out a remarkably poor correlation between symptom severity and actual esophagitis. You could have super mild heartburn that is secretly hiding severe mucosal erosion, or you could experience agonizing, severe heartburn and have barely any actual tissue damage at all. It's crazy, right?
So to solve this invisible mystery, doctors will first look at your history of recurrent heartburn. But to really know what's going on, they rely on the absolute gold standard, 24-hour esophageal pH monitoring. They literally fix a tiny pH probe just 5 centimeters above the LES to record every single episode where the acid level drops over a full day and night. If they need to see the physical damage, they'll use endoscopy to confirm erosions, or they might use a barium swallow X-ray with you positioned head down to actually watch the fluid physically move backward from the stomach.
And this is exactly why we can't just ignore chronic GERD and pop mints all day. Left unchecked, chronic exposure to acid can lead to apeptic stricture, which physically narrows your esophagus. It can literally mutate the cells of your esophagus into something called Barrett's esophagus, which is a major risk factor for actual esophageal cancer. The acid can even aspirate into your lungs, causing pneumonia, or create bleeding ulcers that lead to iron deficiency anemia. The stakes are just so much higher than a little after-dinner discomfort.
Which brings us to our final section, Section 5, Putting Out the Fire. Let's see how medical science systematically puts out this fire, step by step.
Managing GERD is definitely not a one-size-fits-all solution. It's a very careful escalation of interventions. The goal is always to relieve symptoms and prevent those severe complications we just talked about. So treatment starts with simple gravity and lifestyle changes. Then it steps up to over-the-counter chemical neutralizers, advances to heavy-duty prescription blockers, and if all else fails, moves right to actual structural rebuilding.
Our very first line of defense is lifestyle management. And you know, sometimes the easiest fix is just letting physics do the heavy lifting for you. Elevating the head of your bed at night uses simple gravity to fight the upward flow of acid while you're sleeping. Combine that with weight reduction to take the pressure off your abdomen, alongside critical habit changes like cutting back on alcohol and the absolute cessation of smoking, and honestly, a lot of patients find significant relief without taking a single pill.
But hey, when lifestyle isn't quite enough, we turn to chemistry. Antacids offer wonderful immediate relief. They physically neutralize the acid in the stomach, and some formulations actually create a literal foam raft that floats on top of your gastric contents to physically block the reflux. Pretty cool visual, right? But if you need to bring out the big guns, doctors prescribe proton pump inhibitors, or PPIs, like omeprazole. These are incredibly effective heavy hitters that work right at the cellular level to inhibit the gastric pump, shutting down acid secretion by a staggering 90%.
Finally, for those patients with severe symptoms confirmed by that 24-hour pH monitoring, the ones who simply can't stay on high-dose PPIs forever, there is a surgical option. It's called the modified Nissen fundoplication. Surgeons essentially take the top part of the stomach, the gastric fundus, and physically wrap it around the esophagus. By doing this, they manually recreate that high-pressure valve that the failing 4-centimeter LES muscle just can't provide on its own anymore. It's a structural fix for a structural problem.
Which leaves us with this final thought for today's explainer. Considering how our modern lifestyles, filled with caffeine, rich foods, high stress, and constantly sitting down, are continually bombarding that delicate 4-centimeter band of muscle, we have to ask ourselves, how much longer can your plumbing hold out against the burn? Thanks so much for joining me as we explored the fascinating mechanics behind GERD. Until next time, stay curious and seriously, take care of your plumbing.